Oh, now we're live stream, guys.
All right, I am out.
I don't. Okay. You guys are fine. Let me make sure I have the share thing here. I do, so we're okay.
Yes, please. And yeah, Kate, I just wanted to let you know Dr. Napisa, she's from Thailand. She's a cardiovascular radiologist, so she would be moderating this session. So I will open up the
That's great.
session and I'll hand it over to her, and she'll take it from there.
Great.
Thank you.
Nice to meet you.
Pleased to meet you. It is an honor to be here. But go ahead. I'll just chime in whenever you tell me to start.
Yeah, sure. Um, Perfect. All right, a pleasant good morning to all our attendees here, to the moderators and speakers, all the panelists. I'm Dr. Janardana Panatapura, JP, one of the cardiothoracic radiologists from Wake Forest University. So the Global Academic Radiology Education Program, which is a nonprofit initiative, this is aimed at providing high-quality radiology education to colleagues worldwide. So it's established in October 2021 and based at the Department of Radiology at Wake Forest University School of Medicine. It offers free online educational resources and live webinars featuring academic radiologists from leading US institutes. This program is designed to bridge educational gaps, particularly for radiologists in resource-limited settings, by sharing expertise and fostering global collaboration. So we host bi-monthly webinars, which starts from January to October, covering various radiology subspecialties. The sessions are well attended, up to 700 participants per live event, and include contributions from esteemed institutions. And we reach extends to radiologists in different countries, including Africa, Asia, and Middle East. The program's success is driven by dedication of its committees, moderators, and speakers who work tirelessly without external funding. In addition to webinars, AREP also offers projects like the Radiology Excellency Program, with focus on mentoring and specializing radiology challenges in various countries. So today, we have another great session on cardiothoracic subspecialty by Dr. Lauren Ketai. And our session is being moderated by Dr. Napisa Bunag. She's a radiologist, cardiovascular unit at Department of Radiology at King Chulalongkorn Memorial Hospital from Thailand. Over to you, Dr. Napisa.
Hello, everyone. My name is Nafisa Bunnak, and I'm a radiologist from cardiovascular unit at King Chulalongkorn Memorial Hospital in Bangkok, Thailand. It is my great pleasure and honor to serve as the moderator for today's educational event organized by the Academic Radiology Education Program, or AREP. On behalf of the organizing committee, I would like to warmly welcome all of you to this international academic session titled Imaging of Pneumonia, a Comprehensive Review. We are very excited to have all attendees joining us from across the world. Thank you all for being with us and taking time to be with us today. And now it is my great honor to introduce our guest speaker, Dr. Lauren Ketai, Professor Emeritus of Radiology at the University of New Mexico and a thoracic imaging specialist with a unique background in both internal medicine and radiology. He is internationally recognized for his work in thoracic imaging. Dr. Ketai has received multiple teaching awards, published extensively, and currently serves on the Executive Council of Society of Thoracic Radiology. We are truly privileged to have him here today. So without further ado, please join me in welcoming Dr. Ketai as he presents his talk on imaging of pneumonia. Dr. Ketai, the floor is yours.
Thank you very much. Let me go ahead and share my screen. And okay. Oop. Okay, I'm hoping everybody can see that. Please let me know if you can. So,
Yeah.
hi, I'm from the University of New Mexico, and those of you um, who haven't had a chance to come to the U.S. or to the Southwest of the United States, this is sort of what it looks like around here. This is about an hour's drive from my house, and the other thing I'll say is New Mexico is really known for its natural light. Um, for instance, this is a picture outside my street one day in the winter, and then this is another picture taken just 5 minutes later when the light changed. So infections aren't going to be as dramatic as that, but we are going to talk about infection today, and I think it's important to know what our clinician friends expect of us. Radiology is going to be important in detection of imaging very commonly. Very commonly, the question will be, can we differentiate infection from non-infection? And then occasionally we're going to find it complications, and really only rarely are people going to be asking us to try to identify a specific organism. Okay. Learning objectives for today is when we're done, I think you'll be comfortable with the CT appearance of passive atelectasis, obstructive atelectasis, and how that differs from lobar pneumonia. You can rank micronodules in their relative risk of representing infection versus non-infection. You'll know an abbreviated algorithm for evaluating a reverse halo sign. Three imaging manifestations of necrosis caused by pneumonia. And last, name two infections other than TB that cause chronic fibrocavitary pattern on imaging. Okay. And to do those, we're going to first start talking about the detection of infection, then talk about patterns that you can see on CT and chest radiograph, lobar pneumonia versus atelectasis, bronchopneumonia, then linear interstitial pattern. We'll move on to talking about patterns that are best evaluated on CT, which are micronodules, lobular opacities, and segmental consolidation. And then finish off by talking about complications, mainly necrosis, because we really don't have time to go into pleural disease in depth. And then very briefly, specific organisms, but only those that relate to chronic cavitary disease. Okay, so what about detection? Is chest X-ray, is it pretty good? In one study from last decade, when the chest X-ray was positive, the CT was negative in a third of the cases. When a chest X-ray was negative, the CT was positive in a third. So certainly chest radiographs aren't perfect, but skill does make a difference. And those of you looking at this picture, I'm sure many of you have seen that the pneumonia is subtle, but it's present here on lateral view only in the retrosternal area. One thing that can help you if you look at the record or your clinician tells you that they hear crackles. Oh, and by the way, yeah, this is the CT confirmation that that is real. If the clinician tells you that they hear crackles on physical exam, look harder because those crackles on exam were present in many of the chest radiograph false negatives. So look extra hard in the place that your clinician heard rals or crackles. So in terms of patterns of community and acquired pneumonia, radiologists agree best on whether there's lobar involvement and also whether there's pleural effusion. And I should say that it is important to report the number of lobes involved because multi-lobar pneumonia is going to drive clinicians to do more extensive testing, that is blood cultures, urine antigen, etc., urine antigen testing, etc. So report the number of lobes. So we're pretty good at lobes. We disagree with each other when it comes to more subtle findings such as peribronchial opacities, bronchial wall thickening. As you can see in this case, which is more evident on CT, these subtle findings are often difficult to differentiate from non-infectious disease. And in those cases, CT evaluation of micronodules can help. And of course, we're going to talk about that later. So what about patterns we see on chest X-ray and CT? We mentioned lobar pneumonia. That starts in the alveoli. Air bronchograms are present. Often the opacities are homogeneous and there is little or no volume loss. Atelectasis can appear very similar as you see on the right, but volume loss is conspicuous if more than half a lobe is involved. So can CT help? Well, we usually don't do CT specifically for that, but if you happen to have a CT that's been performed with contrast enhancement, here are some things to look for. In passive atelectasis, the volume, of course, is diminished. The fissures are shifted, as you can see here, a normal fissure, and here, this retracted fissure. Vessels and bronchi are crowded. And in the setting of passive atelectasis, air bronchograms are common, just like you see in pneumonia. But what is different from pneumonia is the passive atelectasis tends to be high in attenuation. You can see this enhancement compared to this large area of pneumonia. Again, you can see this here, pneumonia and passive atelectasis, much higher in attenuation. This difference in attenuation between passive atelectasis and pneumonia is much more evident on CT angiogram. So if you've gotten a CT angiogram to look for an embolism, these findings are going to be more apparent. Obstructive atelectasis is a little different. The volume loss is variable, and because the bronchi are occluded, air bronchograms are often absent. Okay, unlike pneumonia and unlike passive atelectasis. Additionally, it can be this area of obstructive atelectasis can be low in attenuation, similar to pneumonia. So here you can see passive atelectasis with air bronchograms, high in attenuation, obstructive atelectasis in this case, which looks much like pneumonia in that it's low in attenuation, but unlike pneumonia, there are no air bronchograms. So one way of thinking about this, if you happen to get a PECT and you're thinking about infection, look at it, look for enhancement. If there's a lot of enhancement and there's considerable volume loss, you're probably looking at passive atelectasis. If the attenuation is not high, then look for air bronchograms. If there are air bronchograms, probably looking at pneumonia. Volume loss can be variable. If there are no air bronchograms, at least think about the possibility you're looking at obstructive atelectasis rather than infection. There are some other things. This is a simplified algorithm, so certainly there are other things that cause low attenuation, such as pulmonary infarctions, if it's chronic adenocarcinoma, as pictured here on your right. Okay. A variant of lobar pneumonia is a round pneumonia, which can mimic a lung mass, as you can see here. And it's important to think about this as possibly representing pneumonia because it can resolve. These round pneumonias are common in kids when they're most likely represent pneumococcus, but they can occur in adults, sometimes from community-acquired pneumonia in North America, from fungal disease, and in Asia too, if it's caused by cryptococcus, and by Q fever, which is uncommon. I think one of the most important things to recognize, though, is that a round pneumonia can cause a 4B nodule on lung cancer screening. So in the screening lung cancer guidelines for a new large nodule that develop on annual screening, a 1-month low-dose CT may be recommended. So in this case, as you see here, this looks like a lung mass, but it is a round pneumonia. The follow-up CT shows it's nearly completely resolved a month later. Bronchopneumonias are a little more subtle. They're patchy peribronchial opacities and bronchial wall thickening, often accompanied by micronodules. And they can be pretty subtle on chest radiograph, more evident here on CT, where you can see peribronchial opacities as well as numerous nodules. Air bronchograms tend to be less conspicuous, certainly early on, like in this case, where you see mainly peribronchial opacities and bronchial wall thickening. But as the disease progresses, air bronchograms can become more conspicuous. Now, does this pattern help us to talk about predict an organism? And as I said before, often that's not what the clinicians are looking for. So a lobar infection does favor bacterial infections, but just specifically or particularly if cavitation is present, as you can see pictured here. However, some infections, like pictured on your right, can have both a bronchopneumonia and a um, lobar component. So that makes it a bit more complicated. And bronchopneumonia occurs in both bacterial and viral pneumonias. So really, except for the lobar pneumonias and those with necrosis, it's going to be difficult for us to predict bacterial versus viral infection. Remember, at least in our clinical community, clinicians are going to be looking towards biomarkers to help them with that. The most commonly used one is procalcitonin, and I encourage you to look in the charts if these are obtained at your institution, because it'll help you get a feeling for whether the clinicians are favoring bacterial versus a viral infection. All right, the last pattern on chest radiograph that we're going to talk about is a linear interstitial pattern, which, as you know, is most commonly seen in the setting of edema. The arrows here point to thickened fissures, which are characteristic of this abnormality. This linear interstitial pattern represents enlargement of lymphatics, which occur in the secondary lobule along its wall and in the center of the secondary lobule. So that these are manifest by bronchial wall thickening and curly B lines. As you can see here on the CT, as well as on the chest radiograph. Now, this pattern is most commonly seen in CHF, but can be seen in lymphangitic carcinoma and a few other entities. A linear interstitial pattern that's predominant is rarely seen in infection. So a predominantly linear interstitial pattern usually is not infectious. Exceptions, hantavirus, especially if cardiac dysfunction is present, and in scrub typhus, as well as some rickettsial infections. You will see an occasional thickened interlobular septum in other kinds of pneumonia, but it's usually intermixed with many other abnormalities, here widespread consolidation. So if it's just linear interstitial, couple of organisms to think about. The other point when we talk about linear interstitial is make sure you're looking at linear interstitial. And sometimes it's hard to distinguish this from a micronodular pattern. So if you look at these two, one of these is linear interstitial, the other is a micronodular pattern. If you look carefully and pick A or B, the micronodular pattern is B in this case. Let's try one more. One is linear interstitial, the other is micronodular. Give you a moment to take a pick. In this case, the micronodular pattern is B. So let's talk about micronodules, which are hard to characterize on chest radiograph, but can be evaluated on CT, and it helps to do that because you can help distinguish infectious from non-infectious diseases. We're going to talk about central lobular nodules with tree and bud, central lobular soft tissue nodules, random nodules, central lobular ground glass nodules, and perilymphatic nodules. So the first, which many of you are familiar with, are tree and bud nodules, small nodules which spare the pleural surfaces and are interconnected by branching structures, as you can see here in this CT. These are most commonly infectious. Not any specific infection, though. They can be mycobacterial, such as TB. They can be bacterial, in which case the most characteristic infection would be Haemophilus influenza. You can see them in mycoplasm, usually in adults as pictured here, and in viral infections as well. These are the four most common viral infections to cause extensive tree and bud. In this case, there's a picture of influenza causing tree and bud. Now, tree and bud nodules are very, very commonly infection, but there is one other entity that is common that can cause a similar appearance, and that is aspiration, which does tend to be more dependent, but not exclusively. Okay. Central lobular nodules don't have to be tree and bud, and sometimes they're a little bit bigger and denser and referred to as central lobular soft tissue nodules, as pictured here. These nodules are heterogeneous in size, they're patchy, and they're often seen in infections as well, in which case they probably represent acinar consolidation. You can see them in aspiration as well, and if chronic, sometimes in adenocarcinoma. Now, central lobular nodules that are much fainter, so their ground glass opacities, also occur. You can see here, these nodules, again, spare the pleural surface, but are much less dense. These are central lobular ground glass nodules, and they are usually, or most commonly, not infectious in origin, if that's all you see. So in the setting of exclusive ground glass central lobular nodules, think about hypersensitivity pneumonitis and in smokers, respiratory bronchiolitis. It can also be seen in pulmonary hemorrhage, and more recently, they've also been described in vaping-associated lung injury. Okay. So we finished now with central lobular nodules and move to a different distribution that is random, and where the nodules randomly contact interlobular septum here and pleural surfaces, and can appear adjacent to bronchovascular bundles. This is seen in infections. Certainly miliary TB is the most famous, and in North America, we'll see them in endemic fungal infections. A very similar appearance, however, can be seen in metastatic carcinoma. Again, two different pictures. One is miliary tuberculosis, one is metastatic carcinoma. If I don't have the labels here, I really can't tell them apart. And you can see miliary TB on your left. So if you see this pattern, sort of a toss-up as to whether you're looking at infection or neoplasm, and you have to rely on your clinicians and to help you make that differentiation. The last nodule pattern I want to talk about is perilymphatic nodules. These are nodules that preferentially, like the interlobular septum and the central lobular and the bronchovascular bundle, because that's where lymphatics live. And CTs, these nodules tend to be clumpy and cluster along bronchovascular structures. The important thing from an infection standpoint is these nodules usually represent sarcoid silicosis or lymphangitic carcinoma. Very uncommon for these to be infection. So if you're confident you're looking at perilymphatic nodules, the likelihood of infection drops quite low. So just to review that, central lobular nodules with tree and bud, infection more common than non-infectious. Central lobular nodules, soft tissue nodules, still more likely infectious. Random nodules, sort of a toss-up, could be either infection or non-infection. Predominant central or exclusively central lobular ground glass nodules, probably non-infectious, and perilymphatic nodules, not infectious. Okay. A couple more patterns which we're going to talk about more briefly that are evaluated best with CT The first of those are lobular opacities, and these are are described as opacities with geographic borders that are very well defined. These are common in infection, such as in bronchopneumonia. And usually when you see those, you'll see other signs to suggest a bronchopneumonia, such as in this case of influenza, where the opacities are peribronchial. There is an infection that causes lobular ground glass without a lot of airway abnormalities, and that's PJP, and it's something that obviously is suspected in the right clinical setting. Unfortunately, lobular opacities are not particularly specific and occur in a lot of other non-infectious diseases, most commonly hemorrhage and edema, hypersensitive pneumonia, and other less common etiologies that I've pictured a few of them here, all of them showing these nice geographic, well-defined borders of the ground glass or consolidation. There is a kind of focal consolidation or ground glass that is a bit different that we should talk about, though, and that is our segmental opacities. They can occur in infection and often do. But when you're looking at something where you're thinking about infection and you see a segmental opacity, it's important to remember the possibility of pulmonary infarction. Infarctions tend to occur in the lower lobes and are peripheral and have a truncated apex. But these qualities really don't distinguish them from segmental infection. What can distinguish them is a vessel sign, meaning an enlarged vessel extending to one of these peripheral opacities. This is pretty specific, but unfortunately not very common. Infarctions also rarely have air bronchograms, and it's important to note this finding. They often show a segmental opacity with a central lucency. As you can see here, whoops, go back one. As you can see here, okay. This appearance of a segmental opacity with a central lucency is not extremely sensitive, but does occur in pulmonary infarctions. And if you look in the literature, this is billed as being very specific. So this does certainly suggest a pulmonary infarction, but it's important to identify the clinical context because this appearance of consolidation with a central lucency is also fits the description of a reversed halo sign. And so this appearance can be an infarction, but in the right clinical setting can represent other diseases such as an immune-compromised host, this case of mucormycosis with central lucency and consolidation on the periphery. So there is a sort of a way to go about thinking about this when you see it. If you think you're looking at a case of infection, the first question you ask is the patient's neutropenic? And if they are, then you think of angioinvasive fungus. If they're not neutropenic, could be other things. We certainly saw quite a bit of this in COVID-19, but you can see it in post-infectious organizing pneumonia as well as in this case. If you're thinking it's not infection clinically, think about pulmonary emboli. And so that's very important as in this case with an infarct. If it's not an infarct, and you've ruled that out with a CT angiogram, other possible causes include cryptogenic organizing pneumonia and granulomatous polyangiitis, and occasionally drug toxicity. Okay, we're going to move on to talk about complications of pneumonia, and we really don't have enough time to talk about pleural disease or chest wall invasion, so we're going to focus instead on cavitation and necrosis and those manifestations. Early on, necrosis can cause lobar expansion. And the other clue to look for, because lobar expansion is sometimes hard to delineate, is to look for focal lucencies, such as you can see here in this case of pneumonia with with necrosis. It's important to remember, though, that pneumonia with Lucent seizures also commonly represents pneumonia which is superimposed on emphysema, as in this case. So let's take a look at this case. Community-acquired pneumonia, day 1, peripheral multifocal consolidation. But unfortunately, on day number 6, the radiograph looks like this, where there are heterogeneous lucencies and maybe some expansion with some increased volume in this hemithorax. And on chest CT, we see these findings. This is diffuse necrosis. You see non-enhancing parenchyma, which is so low in attenuation that it approaches water attenuation, often without discrete borders, but you will see air locules, as we saw in chest radiograph. The things to consider when you see this are staphylococcal infections, probably a little more common with MRSA, pneumococcus, and Klebsiella. And patients with this finding can do well clinically, but they often have a prolonged hospital stay. And on follow-up radiographs, you often see evidence of volume loss. More common manifestations of necrosis include pneumatoceles and abscess. Pneumatoceles are focal areas of necrosis which allow air to insinuate into the pulmonary parenchyma. And because it displaces the parenchyma rather than destroying it, they're thin-walled. And because they're thin-walled, as in this patient, they're often associated with pneumothoraces. Abscesses actually destroy the lung. And because of that, vessels may end abruptly at the margin of the abscess. Abscesses also tend to have thicker walls, which are irregular. They're associated with empyemas, which brings up another point. If you do see an air fluid level, it's important to make sure that you're looking at an abscess to determine whether you're looking at an abscess or an empyema. Abscesses tend to be round, have irregular inner margins, and the vessels truncate at their margins, as we see here, and of course are treated with antibiotics. Lenticular collections suggest an empyema. The margins tend to be smooth, and if you look carefully, vessels tend to be deviated away from them rather than truncated. And these, of course, are treated with drainage. So in this case, if you look at this picture, I'm hoping you're thinking, gee, this looks like an abscess rather than an empyema. However, in this case, there was some confusion, and because it was felt to possibly represent an empyema, instrumentation was performed and unfortunately resulted in this widespread loculated pleural effusion. So it's important to remember to make the differentiation on imaging between an abscess and an empyema, because catheter drainage can transform an unruptured abscess into an empyema. The last complication of necrosis I'm going to show you before we finish by looking at a few organisms is this complication. I don't know if you folks, I'm sure there are those of you who are watching have picked it out already. There is an abnormal contrast collection here next to the pulmonary artery, which is a mycotic pseudoaneurysm. These come in two flavors. There are those pseudoaneurysms caused by direct extension from the chronic pneumonia. These are usually single and classically occur in tuberculosis, but can occur in other organisms as well. This was a case of tuberculosis. And because they're single, they usually are amenable to embolotherapy. Now, in our practice, we usually see pseudoaneurysms of a different flavor, and these are caused by the hematogenous spread of infection, typically staph. And because they're hematogenously spread, they're often multiple. Oops. And because they're multiple, they can be problematic to embolize. They're usually segmental or subsegmental arteries, and they can be missed, and I've definitely seen them missed because initially they can't they're particularly hard to pick out when they're fusiform rather than round. Okay. And as I said, we're going to finish off just talking briefly about specific organisms, namely those that can cause chronic cavitary infection, mycobacterial disease, and aspergillus. Now, so many of you watching are experts in TB. I was hesitant to put this slide up, but again, primary TB patients unsuccessful at suppressing infection, initially children, adolescents, some types of immune suppression. Post-primary patients are partially able to suppress infection, usually can manifest soon or more commonly late after exposure. And then miliary TB, which can be a complication of either. I'm not going to say much about primary TB except to remind you that it's one of the few kinds of infection that causes adenopathy large enough to be visible on chest radiograph. So primary TB pattern. The other things to think about in North America, we think about fungal disease. Other rare infections cause it, plague, tularemia, anthrax. And the other thing to always think about if you see pneumonia with adenopathy is there an underlying bronchogenic carcinoma? Well, let's turn to cavities. So post-primary TB, as you know, affects apical and posterior segments of the upper lobe, superior segments of the lower lobe. Capacities tend to be patchy, ill-defined. And although many kinds of pneumonia can cavitate, TB tends to cavitate even when the areas of disease are relatively small. You can see cavities in 20 to 45% of radiographs and more commonly with CT as seen here. Once the cavities occur and material excavates into the cavity, you can develop subsequent TB pneumonia, lobar pneumonia, or in this case, as you can see, bronchopneumonia. In addition, the other manifestation of TB that I think I like to remind myself of is it can be found in small foci distant from the main foci due to endobronchial spread. And these can present as sort of large nodules or relatively large nodules. In some cases, you can see that these nodules have developed from the coalescence of smaller nodules, which is termed a galaxy sign. And this can be seen in sarcoid as well. Now, sometimes clinicians ask us to differentiate active from inactive disease and TB. And so active disease tends to have central lobular nodules, some with tree and bud, tends to have more lobular consolidation and ground glass. Cavities tend to be thick-walled, etc. It's also important to remember that in multi-drug TB, these thick-walled cavities, these cavities tend to be thick-walled as well and more numerous, as in this case of multi-drug TB you see at the bottom. But whatever you see, remember that the CT cannot replace sputum cultures for determining activity and then drug sensitivity panels for determining whether you're looking at MDR or not. Now, in the United States and Europe, non-tuberculous mycobacteria has far outstripped tuberculosis, and it's also increasing its prevalence in Asia. Particularly, it's been published in South Korea. Now, most commonly, we see this non-classic pattern of non-tuberculous mycobacterium, which is manifest by bronchiectasis and nodules, classically more common in the middle lobe and lingula. But there is a classic pattern which looks like TB, as you can see here on your right, tends to affect elderly males with obstructive lung disease. It looks like post-primary tuberculosis, but the cavities tend to be more thin-walled, as you see here, and these patients are more likely to have unilateral disease. The other thing that's very common in this classic pattern is associated pleural thickening, as you can see here on chest radiograph and CT. I'd like to close by just mentioning aspergillus, which is a complicated topic and could be a lecture unto itself. But the important thing to remember about aspergillus is that its manifestations are going to be dependent on the level of your immune system activity. For the purposes of this lecture, I just want to focus on the two middle forms, that is aspergillus and chronic pulmonary aspergillosis, which are closely related. The most important thing about chronic pulmonary aspergillosis, which does occur in patients with underlying lung disease, such as TB and COPD, the most important differentiation between it and aspergilloma is that the fungus tends to evade adjacent tissue. Okay. This is a problem worldwide. It may affect up to 20% of patients with cavitary TB, and it can mimic TB reactivation. A good article out of Vietnam noted that it occurred in half the patients who had treated TB but prolonged respiratory symptoms. So it's something important to think about. Where TB is rare, here we more commonly see it in middle-aged and elderly men who present with cough, fever, and weight loss for several months. Manifestations, okay, excuse me, I'm so sorry. Here we go. As you can see here with volume loss, etc. There are some subcategories which I don't think you need to know because they're not well differentiated on imaging. The imaging characteristics to remember, as we saw in that last chest radiograph, is they initially start in the upper lobe, cause chronic consolidation and cavity formation, and pleural thickening. And some of the subcategories can progress to bilateral fibrosis. The other thing to remember is they are related to aspergillomas. They're just a step further in the progression of disease. And because of this, they may have concurrent aspergillomas, as you can see pictured here. All right, we talked about a lot. Let's just go over the learning objectives and then I'll stop. If you want to differentiate at the CT appearance of passive atelectasis and pneumonia, passive atelectasis has high attenuation, obstructive atelectasis is low attenuation, but no AREP bronchograms, whereas pneumonia is low attenuation, but does have AREP bronchograms. If you're going to rank micronodular patterns on CT, tree and bud is very touchy. Tree and bud is very likely to be infectious. So is our soft tissue central lobular nodules. Miliary nodules are a toss-up. These are more likely non-infectious. If you see a reverse halo sign, think about, well, is there an infection? If there is the patient neutropenic? If there's no infection, think about looking for pulmonary infarct. Manifestations of necrosis include hypoattenuation, lung abscess, and pneumatocele, and uncommonly pseudoaneurysms. Other things that can cause fibrocavitary patterns besides TB include non-tuberculous mycobacteria and, importantly, chronic pulmonary aspergillosis. In North America, we think about cocci and other endemic fungi in the Americas, excuse me. And in your part of the world, I know that some of you have seen cases of myeloidiosis and are probably experts in it, know far more about it than I do. So with that, I'd like to close. This is pretty much what it looked like when I got up this morning here in New Mexico. And I really thank you guys for tuning into this. It's a great honor to be here and to have worked in the past with Dr. Trapani and to know Dr. Patel. So thanks so much. Okay, I am
Thank you so
done.
much. Oh. Thank you so much, Dr. Kidai, for the informative and insightful lecture. Now we have time for a Q&A session. For our audience, please feel free to submit your questions in the chat box. I will, or in the Q&A chat box. I will relay them to Dr. Kirtai. Maybe let's begin with the first question. So could you please tell us what is the recommended protocol for CT and what is the indication for CT in the patients with suspected pneumonia?
I think that is a great question. And which is going to depend on the resources that are available to you. I think it's important to say this, that if I, in the setting of where clinicians suspect pneumonia, but you don't see anything on chest radiograph, many times the clinicians will begin therapy with empiric antibiotics. So what I'm saying by that is the clinicians will often treat even if the X-ray is negative. So you're not compelled to get a chest CT to prove that there's infection. I think in the setting where the chest X-ray is negative and the clinician is unsure whether they're dealing with infection or something else, then it's warranted to move on to a chest CT. The other time that chest CTs are most useful is when you suspect a complication. And in those situations, for instance, developing pleural effusion or enlarging pleural effusion, or particularly if there's an air fluid level, then I think they become mandatory. Otherwise, I still look at them as a problem-solving device to be used when there's clinical uncertainty. I hope that helps a little, but you're right. It's a big question.
Yes. And so regarding the talk of the effusion and empyema, so we have the question about, do we need to delay the scan to see empyema?
You guys are great. That is a great question. Um, if if the specific clinical question is is this a par is this a fusion? Okay. If the request comes to evaluate for empyema, then I guess I will do a delayed scan because I do think the pleural enhancement is more conspicuous. But I don't think it's absolutely necessary. It's important to remember one thing, and this is, I think, important when you talk to your clinicians, is the presence of enhancing pleura is important in that if it's absent, if the pleura does not enhance at all, it's unlikely to represent an empyema. If it does enhance, however, it still could just be a inflammatory parapneumatic effusion, but not be an empyema. So the fluid has to be sampled to make that differentiation. Of course, the only time that you can be 100% confident you're looking at an empyema without sampling the fluid is if there's air in the pleural space and it has not been instrumented prior to the study.
Thank you
So
so
again,
much.
okay.
Yeah, and another question is about the cavitary lesion. So our attendee asked how to differentiate between the infected giant bullae and the pulmonary abscess or empyema with internal air.
Yeah, that is okay. I think the giant bullet question is great. I mean, the whole question is great. I think th- in terms of the giant bulla, um, one of my first professors told me that smart is good, but old X-rays are better. So, so often if I see that, the first thing I'm doing is looking hard for any prior imaging, even if it happens to be, an abdominal study, to see if there really was something there before. And that's, of course, the best thing to find. Infected bulla tend to have thinner walls. Um, and I mean, they tend to have thinner walls, and the inner walls tend to be smooth as compared to an abscess. However, I would be lying if I said that I haven't been confused in some cases and really not known which of those I was looking at. And then for empyema versus abscess, again, the findings we talked about in lecture, um, I think uh, it's a combination of all those findings put together. The smooth, in other words, for an abscess, looking for an irregular wall, truncated vessels, and its round shape. But again, I would be lying to say if that I'd never made a mistake and put a needle in something that I thought was an empyema and had it turn out to be an abscess.
Thank you again.
Okay.
So, we have a couple more questions. I think we can start with the patient with hemoptysis. What is the recommended protocol? Should we prescribe them with the CTPA or the CT thoracic aorta?
Great question. Great question. Um, and you know, I think I'm trying to put myself in the mind of the person that asked the question. I think the real question is, do I think this is most likely coming from a pseudoaneurysm that is off a pulmonary artery, or is this hemoptysis from bronchial dilatation, um, and excuse me, from bronchial artery dilatation that's going to be best seen on the arterial phase. So certainly, in the setting of cystic fibrosis, et cetera, then I'm going to time the scan to be during arterial phase. If it's somebody with known staphylococcal bacteremia, then I'm more likely to get a CTPA. And if I'm really not sure, then I might do something like use the arterial protocol, but give a longer duration contrast bolus so I can be sure that I'm going to see good enhancement within the bronchial arteries, but have contrast that's persisted in the pulmonary vasculature so I can pick up pseudoaneurysms. These are great questions, by the way.
Yes. And I think another interesting question is about the differential diagnostic features between interstitial pneumonia and interstitial lung disease. Can you give us some tricks and tips to help differentiating this?
Yeah, that's another, I mean, those are great questions. I think in that setting, of course, I just have to say, because I'm a chest radiologist, I'm dying to see if there's some old study, maybe the lung base is an abdominal CT or something like that. I think for something that would make me um, most confident that I was looking at interstitial lung disease, of course, I'm going to look for evidence of fibrosis, that is traction bronchiectasis or bronchiolectasis, or the presence of some honeycombing, which as long as I'm looking early on in the course of the infection, is going to favor that there was some pre-existing interstitial disease. The thing that's going to make me really favor infection is I'll look hard to see if I see any of those nodule patterns that are associated with infection, particularly tree and bud opacities or soft tissue nodules that are going to push me more to infection. Um, so I'm going to be looking for ancillary findings, either those of fibrosis or those of sort of airway involvement, which will lead me towards infection. But no, it's time again. I think you're asking all you're asking the questions are things we come across all the time and scratch our heads because we're not sure.
Yeah, and I think another pain point for chest imaging for all of us is differentiating between the lung cancer, which present as consolidation, and infection with consolidation. So, is there any like imaging clues that help us differentiating this?
Yeah, I know. That's important. You know, there have been some papers in the past which talked about bronchial dilatation being more common um, in cases of consolidation caused by adenocarcinoma. Um, and the, and I guess the bottom line is I don't know that if I see in the setting suspect of when you're trying to differentiate pneumonia from, let's say, adenocarcinoma, of course, the old studies are the most important. If you see soft tissue nodules, that doesn't really help you because you can see soft tissue central lobular nodules in either of those diseases. I don't think the presence of bronchodilation I found it to be super helpful. What has been helpful is if I can find that there actually are tree and bud type nodules, not central lobular soft tissue nodules, but tree and bud type nodules, then I feel much more comfortable that I'm looking at pneumonia. In the absence of that, if I just see consolidation and central lobular soft tissue nodules, I can't tell without the old radiographs or old imaging of some kind.
Yeah. Um, okay. So we have a lot of questions coming. Um, there's a question about the aspergillosis. So our attendee asks if we can diagnose acute aspergillus pneumonia on imaging. Is there any imaging signs to suggest
Yeah,
in
I think
activity?
again, and now when you're asking that question again, I'm assuming is you're only going to see that in the setting of profound immune compromise, usually profound neutropenia. So I'm looking for people that aren't transiently neutropenic. I'm looking for somebody who's been neutropenic for at least 10 days. There's certainly a lot written about, I think the early signs you're going to be looking for are a ground glass halo, central nodule with a ground glass halo. The other sign that's been written about, which I sort of like because I think um, it's can be compelling, can really raise the likelihood that you're looking at angioinvasive aspergillus, is if you do a contrasted CT in that case, you can see the vessel enhanced up to the nodule and then truncated. That finding a sort of a truncated vessel in the settings, particularly if there's a nodule or opacity with a halo, would strongly suggest aspergillus. And in fact, I think people would, in general, start empiric therapy at that point rather than waiting for confirmation.
Thank you so much. Um, I think we are running out of time, but it's been so um, wonderful that all our attendees are so active and participating so lively. And yeah, so on behalf of the AREP, I would like to sincerely thank you, Dr. Kitai, for sharing his expertise with us today and answering all the questions so clearly.
Well, thank you so much. It was, really a wonderful experience. You guys, I hope you keep doing this because I think it's really one of the great things that radiology is doing.
Thank you, Dr. Ketai. I know you've done this multiple times for us. For AREP, you have done multiple sessions every year after year. Thank you so much. We really appreciate your support for this education program. And
Okay,
that was amazing. All your images and graphical representation was amazing.
okay, thank you guys. Thank you. I really, it's like I said, this is the kind of thing that made me want to be an academic radiologist in the first place. So, and Nat and Smita, take care of yourselves. I hope to get to see you sometime.
Thank you.
Thank you, Lauren. That was wonderful. I learned a lot too.
Oh,
Thank you.
you guys are the world's experts. I mean, but I appreciate that's very gracious. That's very, very gracious. All right. I will see you. Have a good rest of your day, folks.
Thank you.
Thank you. So that would bring us, I want to thank Dr. Napisa for moderating this session. Thank you, Dr. Napisa. Really appreciate that.
Yeah. Thank you. Those were great questions, by the way. You guys have great viewers.
Thank
Yeah.
you.
Thank you so much.
Yeah, I'd like to thank all the attendings, the moderators, the speaker, and then the panelists for making this session run smoothly. A special thanks for AREP IT team who works behind this to make this successful. Thank you so much. With that, I would like to share our next sessions. Probably you can see this. The next session is, don't forget to log in on April 20th. That's 2 Sundays from now. At the same time, we have session on imaging in tuberculosis from head to toe by Dr. Harsh Mahajan, who is a founder and chair of Mahajan Labs. And he is very experienced and he's professor of radiology. He's from India. So please make sure to log into the next session on April 20th on imaging in tuberculosis from head to toe. Thank you so much.
Okay.
JP,
Bye, everybody.
Yes, thank you, Dr. Kitai, and thank you, Dr. Bunak. Thank you. I have a little announcement here. Please feel free to leave. I'm doing a housekeeping. And for the Radiology Excellence Program, so we work with the radiology residents from Laos. Laos is a small country in Southeast Asia. We submitted 2 abstracts to Asian Society of Cardiovascular Imaging, or ASCI annual meeting, which can happen in Busan in South Korea. It got accepted. That is the update of a Radiology Excellence Program. If you want to know how to be a part of it, go into the official website and read about it. And that is a little update. And we will have more residents who will work with us and submit the abstract to the international meetings. A few more of them coming soon too. That is it for me, JP.
That's wonderful news. Excellent, Nat. Thank you so much for working on them and being a great mentor. All right. So thank you, everyone, and we'll see you all soon.
Thank you, everyone.
Thanks, Dr. Pham. Thank you.